The views and opinions expressed on this platform are of me, myself, and I, not any agency I'm affiliated with. So please do not take what I say personally. Hey everybody, welcome back to another episode on the 22 at the Lips podcast. If you missed the introduction, you're here for whatever reason. Thanks for being here. 20 out of 10 recommend going back to the intro episode to kind of explain what's going on, the title of this podcast, what this is going to be about. I had somebody come back and give me a little bit of feedback that I may or may not have been super clear on what this podcast is going to be about. So some episodes are going to be kind of like I have a general topic, I talk about it, I may or may not rant and vent. Side note, this episode is going to be one of those where I vent and rant. Other episodes, I'm going to have people that I select or have volunteered to get on the podcast, and I'll interview them. We'll talk about either how they're involved in EMS or their connection with EMS and other aspects of, like first responder, the realm of what that entails. So just like the avenues that you can have with being a first responder or in EMS or beyond the emergency medical services and going into the ER setting or beyond that. I have a couple of ideas, but this podcast is kind of just a large, going back to my southern roots, a large gumbo of a whole bunch of stuff. So I'm not necessarily saying that it's disorganized. However, like my life, it kind of is. I'll have episodes where I try to stay on track, stay on topic, and go from there. I'll have my interviews, but I have a general idea of most of the trajectory of where we're going. But again, I'm kind of making this up as I go along. So if you're here for that, if you want to be involved in this, buckle up, enjoy the ride. We're seeing where this thing goes together. So, like I mentioned in the first episode, some of these are literally just going to be rants and venting sessions for me. This is one of them. So the title is something that we all hear in EMS. Taking this time to add back in, if you are not an EMS and you are listening to this, thank you very much. Let me clue you into something. BLS stands for Basic Life Support. It's an EMT basic, a couple of other things added in with that. ALS stands for Advanced Life Support, which is like your paramedics. There's probably a couple more avenues with that, but just to kind of throw that in there, I don't want anyone thinking I'm trying to say something else. Whatever. BLS is Basic Life Support, and ALS is Advanced Life Support. It's the little building blocks. So, continue. I'm pretty sure it dates back to like prehistoric times whenever medics were using masked pants for fractures or whatever, and we're told not to use tourniquets, and we're riding in on like pterodactyls on the way to calls, whatever. This stems from more than just repositioning someone's airway before you throw down an ET tube. Literally a call that I was on that kind of sparked the idea for this episode. It was a while back, but back in the gap, when I was an EMT, me and my paramedic partner were called out in the middle of nowhere for shortness of breath. We walked into a house full of hysterical family members who were scared that their COPD-ridden grandmother was dying. Walked into the back room after almost tripping on the mile-long oxygen tubing where the O2 tank was like in the other room. Love that. But found the patient. She's kind of like bluish gray. She's sitting upright-ish, slumped back on a bunch of pillows that were behind her head. Her chin was on her sternum. She's altered technically. She's mainly responsive to like shouting and painful stimulation. Overall sounded like she was trying to gasp for air. So after administering copious amounts of ma'am and obtaining a satisfaction that sternal rubs only got her mental status up to like a reactive painful stimuli, more so than like the altered or whatever that the family was telling us, the medic I was with wanted me to go ahead and start bagging her with a BVM, and he starts reaching for a tube. And I kind of like, as an EMT, I didn't I didn't feel like I knew more than the medic. I've never felt like that. Even as a medic, I feel like I still don't know anything. But I kind of took a step back and I'm like, man, why don't we just kind of like start small and go big? So instead of starting to bag her from the get go, I kind of just reached over him and removed the mountainous massive pillows that were tucked behind her head and laid her supine, gave a solid jaw thrust, and voila. She took a huge breath. Her O2 sats began to increase from the lower 70s to like the almost 93% room air, something like that. So then the family calmed down because she's starting to get color back. She's responding a little bit better. They then explained that when they walked in, the family dog, or like her dog that stays with her, whatever, was curled up behind the pillows that were already like surrounding her, and they think that the pillows got shoved behind her head further, and that's why her head was like leaning up against her chest basically. Furthermore, it turns out that Meemaw had a stroke a few years ago and basically can't move herself, hence that she was literally just slowly suffocating sitting up on all these pillows. So, stepped away from that call. The medic wasn't mad. We talked about it. Just kind of like, next time, just explain what you're doing, this, that, and the other. And like, yeah, I should have. But Boo Boo the Clown me was trying to save the day. So, this call solidified in my mind that, like, it sounds super cheesy hearing it in paramedic school, but BLS should always come before ALS. And sometimes simple measures provide better outcomes. Fight me on this. If you have any ideas as I kind of talk about things, let me know. But I'm just going to give my spiel. And again, I cannot emphasize enough. Sometimes desperate calls, desperate measures. But just because you hear GCS less than 8, intubate, like it's kind of been drilled in our heads, I feel like, it doesn't always mean you have to try a tube on every low score GCS patient because of the fear that, oh, well, they can't maintain their own airway. Take a step back. Let's look at the whole picture. Let's start small and go from there. For instance, the local drunk frequent flyer that you pick up who's only responsive to painful stimuli will be probably just fine with an NPA and monitoring, even though the GCS is low. Look at the big picture. And I'll be honest, this is kind of a hill I'm willing to die on. I feel extremely uncomfortable pushing more than like 4 milligrams of Narcan on very, very, very rare occasions when the patient needs the 4 or whatever, but they're kind of improving a little bit. I'll reach for 6, but after that, I stop altogether. And no, it's not because I can't tell an opioid overdose and I freeze up. Like one of my preceptors in paramedic school asked me if that's what was happening. I've seen flash pulmonary edema because the medic kept just pushing so much Narcan, and it's terrifying. And maybe I'm just being a little wimp, but like I never want to see that again. And I especially don't want to be the one in the back to have to be handling up on all that. And honestly, maybe I'm the worst, but it's not something that I like to do to get a refusal form on an overdose. And I mean, granted, no, they don't need to just be sitting in the ER when someone else could use that bed. And 99.9% of the time, they are fine. But like, it's because sometimes they're just really embarrassed. Or, I mean, honestly, like, I know it's an overdose patient, whatever, but they can still be ashamed that, like, they've relapsed or that the paramedics got called. They're still people. On the flip side, sometimes more often than not, they're going to act like it is such a shock that they were given Narcan and they came back. Or even recently, someone told us they must have inhaled something when they were cleaning their house or whatever. We found them in a motel, like you're not even home. I've had people say that their sister gave it to them. I don't know. I just want to know what you took. Like that's the big thing. On the flip side, if you end up transporting, it is a whole work of patience, the entire transport. I mean, maybe this makes me sound like a terrible person, but they're trying to give you their entire life story and justify why they're taking drugs. Or they're being a little smart aleck and mouthing off the whole time. Like, friend, I did not ask for this today. And I'm casting 0% judgment on these addicts. Trust me. However, if I can just get them to a point of breathing or that they have some type of spontaneous respirations and I have to BVM them the whole way to the ER, have them wake the patient up because now, like, you're at the ER, and I mean, in a way, like, it's out of my hands. I got you here. It's a 50-50 toss up of maybe they'll stay and get a decent meal, or they'll stay because, like, they don't have any Narcan at home. I will take that route of care of bagging the patient on the way to the ER just to make sure that, like, they're getting adequate O2 rather than just continuously pushing Narcan, because I don't know. I would rather just bag instead of risking pulmonary edema. And I know it's rare. I know, but maybe it scared me and I need to get over that. I don't know. Anyways, I also want to tie in the idea that even though you can, it doesn't always mean that you should. I've heard stories of various patients being flown out of a scene by helicopter that did not need it. And I mean, now they have a bill that's going to be a huge financial burden on them. And you're flying out a patient that doesn't really need it. If you look at the whole call, you look at everything, that patient did not need to be flown. So when that wreck happens, as the helicopter's on the way to your call and they can't respond to it, but you're flying out the abdominal pain because of distance, I mean, who's really winning in the long run? And it's one thing to take in consideration that this job is filled with so many gray areas, but it's another to look at the big picture and understand that some things just they need to be fully considered. And while it's easy to say like BLS before ALS and fix the easy stuff with, easy maneuvers, whatever, we still can't be lazy. We shouldn't take this mantra and kind of exemplify it to a point of like, oh, well, I can just BLS my way out of this call. Like, not always. It should be in the forefront of your mind, but it should also kind of be like your fail safe in a way. You still have to provide the best possible care you can 100% of the time. But stop trying to show out and puffing your pride and just start small unless there's obvious indication for the ALS level of toys and tricks. Okay, so I'm re-recording some of this because I am going back and listening and I don't like some of it. This is all also like from my perspective. I've been in the back a couple of times due to my wild anaphylactic reactions to strawberries and a couple of other things. That is a whole story in itself. The stupid little red fruit. It literally, if I die within the next couple of years, like on my death certificate, I am 99% sure it is going to say due to the small red fruit. I just, anyways. So all of this is in like the perspective of a patient who I don't want the paramedics to show up on scene and just throw on like a nasal cannula at 2 liters per minute and say that, oh, we're 3 minutes from the hospital, so it's fine. Like, please do the cool things, do all of the interventions you need to. Please don't wait. Don't just say, oh, well, there's still somewhat of an airway. Like, I'm not saying I want to be intubated ever again in my life, but I mean, if it keeps me alive, by all means, say less. Don't tease me with a good time. Just kidding. It is not a good time. Do not recommend. Whatever. What I'm trying to get at is that, like, some situations you cannot BLS. Like on a podcast I listened to, a recent episode was about status asthmaticus. And this is a small little plug for one of my favorite podcasts on this planet, the World's Okayest Medic podcast. 20 out of 10 recommend. Mike is very blunt, and if you are worried about foul language, do go in with caution. I'm not saying that I condone that or whatever. However, there is good information on there if you are in EMS. Continuing on with my spiel. So, his recent episode talked about status asthmaticus, and if you have a patient who's calling for respiratory distress, like secondary to asthma, whatever, if you get there and you're like, oh, BLS, they're on some oxygen, start a neb, you're behind the 8 ball game because in that situation, as Mike says, 9 times out of 10, they have already tried a breathing treatment and albuterol several times. So if you go in trying it again, you're behind the 8 ball. You need to do a CPAP. You need to put on Entitle. You need to start a mag drip. There's a million other things you need to do. And this is another one of those situations like anaphylaxis, like COPD, like so many other issues that, yes, you can start small, but again, starting small, sometimes it needs to be, I'm not saying it needs to be skipped, but you need to get past that and move on to the bigger stuff. And I'm not saying that BLS is always the way to go, but I'm going in more of the realm of you start small and you got your building blocks. I told someone recently that kind of came to me with an interest of going into EMS, going into the first responder realm, whatever, that they were asking about like the steps and the processes and whatnot. And I'll back this up 100%. The core of every call, no matter what, is BLS, basic life support, basic skills, basic, an EMT basic can run the call, but there are times, there are disease pathologies, whatever you want to call them. I'm sure I just butchered that. But there are times whenever you need the advanced life support, you need the paramedics, you need, and then, I mean, granted, there are times when the paramedics aren't going to cut it, boys. We got to bring this person to the ER. There's 50 other things going on. Whatever. That's what I'm trying to get at. And I hate that it's taken so long into this episode to kind of incorporate that, but here we are. I want to take this notion in two routes that run alongside another idea, remembering that we are all human. We must give the best care that we can to our patients. But at the same time, we can't expect so much of ourselves that we start holding ourselves in a heroic stance because we're an ALS provider or we know how to save a life. It is an honor to be a paramedic, but you don't have to be a paradouche about it. We have got to snuff out the paragod complex, and this is a battle I will fight even if or when I ever leave EMS. At the core of every intervention, at the core of every treatment, at the start of every assessment, there's a reason why we start with the most elementary basics, A, B, C's. It is literally alphabetical because I guess, we can get pretty dumb. And it helps at like 2 a.m. when you can't think straight because you've been running calls all day and now it's 2 a.m. You got 30-minute nap right before and you're having to look at Meemaw and try to figure out like, oh God, what do I do? Maybe that's just me. I don't know. National Registry in all of its glory doesn't just teach this idea because it can trip people up on the test and psychomotor skills, whatever, but it's to remind us that if you don't have an airway, you have nothing. If the patient's not breathing, breathe for them. And if there is bleeding, stop it, which I think actually now it's CAB, but I'm sorry, I like ABCs, whatever. Just because you can do a cool thing doesn't mean you have to. You should take your education, training, and strive for improvements to the highest level you can. But if you start trying to quiz people on the pH levels of medications as a paramedic, just a paramedic, friend, effective immediately, you can leave. Whatever, going back to the main idea, I want to advocate for the EMT partners and medic coworkers that have to, and I say have to, run these calls with those people. There is a reason why every truck is paired with two people. And no, it's not just so one can drive around. As an EMT, I literally had a paramedic tell me one time, the basics job is to drive me to the call and do what I say. That is not cute. On a call with this job, no matter how insignificant the call is, one person cannot do everything. And just because maybe you can, one person should not do everything. And I understand that on an EMT basic level or whatever, an EMR, whatever it is, maybe they don't know end-tidal capnometry or they don't know how to read 12 leads or draw up medications. If your partner who may not have the same title or certification as you shows a desire, help your quote lower than your level provider understand how to identify certain differential diagnoses or teach them end-tidal capnometry. Teach them how to draw up a med. It is not difficult. Or, I mean, you can even go as in-depth as they're willing to go and teach them why on certain calls you can push certain medications, but it's contraindicated at other times. Like, no, we're not going to defib asystole, and here's why. No, we're not going to give Narcan on a cardiac arrest, and here's why. Let's just give a side plug that Narcan doesn't reverse cardiac death. The patient is in cardiac arrest because the heart stopped beating. The heart stopped beating because the respiratory drive caused hypoxia. The opioid caused the respiratory drive to cease. It is not that giving Narcan is going to reverse the heart having stopped. It doesn't work that way. Stop giving Narcan in a cardiac arrest. I'm sorry. It's cute that you have little stories about how, oh, well, I gave it in a code and it worked. No, it's because you need to go for epi first and defib when you can. Stop being dumb. Going back to the main idea. So, for your partners, for even if it's not your partner, but you know somebody that's an EMT basic or an advanced or whatever, ask them if they have any questions and answer those questions to the best of your ability because maybe you'll realize, that's something I don't know. Wild how that works. We should strive to leave a legacy for other providers that may not have our patch or for each other, for of someone who's hungry for information and wants to learn more, rather than just bullying your partner into being your pack mule and cleaning up your mess or having to deal with your attitude the whole shift. And hint, there's a reason why there are two brushes whenever it comes time to clean the ambulance. I heard it beautifully said once, and I'm paraphrasing because it's been a minute, but it was kind of like a quote or something that went along the lines of the only time a paramedic and an EMT is distinguished is on a call. It's just the scope of practice that sets them apart. After the call, they are both individuals who respond to emergencies together. Granted, that doesn't apply to some people because they're so arrogant, it seethes out of them. So, like, everybody sees and can tell who the medic is. Where I previously worked at, it was a private ambulance service. We did IFT transfers. I can recall specific paramedics that had a reputation for pitching actual hissy fits and pouting about having to take some simple hospital to hospital transfer or take a patient from the ER to a psychiatric facility because they would say something along the lines of, I'm a CCT medic. I can't be held on this call when someone else can do it. Yet these same medics were tickled pink when they're sent over to do a vent transfer and like will even try to steal the call. But when they walk into the ER, they storm to the nurse's desk and start demanding updated ABG levels, completely changing the vent setting and disregarding the RT's recommendations and explaining and over explaining and just making an absolute fool of themselves with this entire vent transfer, and it holds everybody up and it's a mess. Get over yourself. In the EMS field, you are not so above simple calls or tasks that your bravado will be diminished or taken advantage of. If anything, for those medics who would pitch the hissy fits, taking that little transfer could humble you so you could actually fit your pride and big ego-headed self into the truck without struggle. And granted, it was a select few, but it's universal. And I don't write this with angst for a large majority of the partners that I've had. I've had the honor of working with some of the best of the best. And my consistent partners I had back at home and even that I have here in Utah, I've been spoiled being with Class A medics that when I worked with paragods, and honestly, sometimes just the norm of a paramedic, I would get so angry with the absolute indifference to them having a qualified EMT, not that I was, but in general, rather than just like if they'd been stuck with a taxi driver who could follow orders on a call. So it's because of these stellar medics that I've had the privilege of working with that I've just sat back and I've prayed that like one day I could possibly exemplify the team-minded attitude that they showed me and the time they've taken to answer my never-ending questions and just the experience and wisdom and knowledge and time that they just poured into me because it is something that it's been a minute, but I still treasure it to this day. So for now, rant over about paragods, just so you know how I feel about them. At times, we need to take a step back and realize that if we don't fix the ABCs and overall fix what we can first before moving to the more advanced procedures or pushing meds, whatever it's going to be, we're going to skip over some of the basics that can be fixed and possibly forego some of the other stuff. Not that we're trying to get out of interventions or anything, but sometimes less is more. Not always, case to case varies. And I've had it happen to me. You may be taking so much time going down a rabbit trail of should I start a mag drip that you literally miss that there's something else going on with the patient. But because you missed it, you may arrive at a completely different differential than where you should be. And this is something I still kind of struggle with, but it's just the idea of like, don't get so tunnel visioned and be so wrapped up in that super cool thing you want to do or the super cool way of doing something that you miss the baby steps. Am I against doing above and beyond treatments and giving aggressive care to your patient and having pride in your job? No. Am I against striving to do more and to learn more and be the best medic ever? No. In fact, I'm prideful enough to admit that most of the time I push myself and I'm fairly hard on myself to be the best medic out there, but simultaneously, I'm also able to say that I am not, by any means or measure, like 1/16th close to being the best medic ever. We're all growing. Am I saying that anyone who wants to shine and look like a hardcore medic because of their skills is a bad person? No. I mean, catch me gloating and flipping my hair out of my face and trying to act like I'm in some Maybelline commercial as we walk into the ER because I snagged the bilateral 16 gauge IVs and what looked like the arms of cobweb spidery veins and had an amnio drip initiated in like the 6 minutes it took us to get to the ER from leaving the scene. But you could also find me 5 calls later with a 0% IV success rate because the EMS gods decided to make me a solid dish of humble pie. So, a big reason I try to be an advocate for staying humble is because 9 times out of 10, the people who didn't brag about what they've done when I've worked with them are the ones with the coolest experiences, but they don't try to outdo anybody else. This job is not some contest. This job and the motive of you telling that story to one up yourself is only going to gratify you and you, while everyone else is internally rolling their eyes and you get labeled as the paragod because I'm sorry, I want to hear your story, but nobody likes bragging. This job is not to one up anyone. It is not to make yourself look cool or seem more important than you are. This job, first, is to treat patients. Next is for all of us to work together and improve the entirety of this profession. I am fully aware that I am all over the place with this one. I've worked on trying to organize it and get my thoughts together, but I've just word vomited, and that's fine. So, my main points are 1. A lot of factors indicate so many aspects of each call. They are dynamic. You literally walk into the unknown with every single call you have. When you can, start small and work towards the bigger things. Every call is different, but every intervention, every assessment, every type of call starts with the basics, your ABCs, or CAB, whichever one you want to go with. Number 2, paragod status doesn't look cute, and it leaves a bad taste in everybody's mouth but the one with the paragod complex. If at any point you ask yourself, am I a paragod? You should evaluate. It is a deadly disease. You're going to kill any sense of humility you have, and because of your bravado and ego, you could potentially kill your patient. And if nothing else, nobody wants to work with a paragod. Your other coworkers, and I'll even go as far as to say the ER nurses and doctors, can sniff it out, and it makes the rest of the field look bad. You've started out on the same level as the same people you think you're better than. Have a back seat. And lastly, number 3, your partner can be your biggest asset. And if they have questions, if you guys struggle in some area, whatever it is, you should be asking questions. You can teach each other stuff. You can instruct any basic that you know or advanced EMT that you know if you're a paramedic, whatever it is. And we should strive to invest in one another and be the best that we can because, again, at the core of every call, no matter who the patient is, what they're calling for, they deserve the best that we can give them. And if you disagree with that, you can find yourself another job. Get out the field. So guys, if you have any questions, comments, concerns, future topic ideas, please email me at 22 at the lips podcast at gmail.com. Again, that's 22 at the lips podcast at gmail.com. Thanks. Never stop learning and be safe out there, friends.